Welcome to the Hospital Medicine Unplugged podcast.
Great to be diving into this. Today we're tackling acute myocarditis. It's one of those diagnoses that, well, it keeps hospital physicians on their toes.
Definitely. It's this really heterogeneous inflammatory condition of the myocardium, right? And then the way it presents is just all over the map.
Exactly. You can have someone with just some chest pain, almost benign, or you can have someone roll in profound cardiogenic shock. That spectrum is what makes it so tricky.
And that variability, that heterogeneity, it really forces you to think structurally right from the beginning.
Yeah.
So our goal today really is to try and cut through some of that complexity for managing these patients when they're admitted.
We're pulling together the latest evidence, things like the 2024 ACC Expert Consensus Pathway, plus some key reviews from JAMA and EJM.
And focusing squarely on how we diagnose quickly, how we risk stratify aggressively, and then how we actually tailor the management based on the cause for these hospitalized folks.
Right, because fundamentally, myocarditis is inflammation of the heart muscle. Simple definition. Often, follows some kind of virus.
Well, there's not just diagnosing it, is it?
No, not at all. The real challenge is spotting that subset, maybe small, but potentially lethal, the patients who are going to deteriorate rapidly.
So how do we as hospitalists deploy the right diagnostics, the right supportive care fast enough to actually make a difference? That's the core question.
That's it. Let's get into it.
Okay, so starting with just how big a problem is this? You don't hear about it quite like ACS, but it's definitely out there.
It is. The global estimates, they quote figures like 4 to 14 cases per 100,000 annually, but I think we both agree.
That feels low.
Yeah, it feels low. It's almost certainly under-recognized. Think about all the mild cases, maybe written off as just a virus, or they get better on their own.
And that under-recognition, that's a potential disaster waiting to happen, right? Because we're talking about a major cause of sudden cardiac death.
Especially in younger people, active adults, it's a huge blind spot.
And even if they get through the acute phase, the long-term hit can be massive. That stat about progression to DCM.
Right, up to 30% of biopsy-proven cases might end up with dilated cardiomyopathy. That's staggering. This isn't just some transient illness for a significant chunk of patients. It can change their whole life trajectory.
And it's those high-risk patients, the ones who get really sick. They're the ones who consume our most intensive resources.
Most adults who come in might actually do okay, have an uncomplicated course, we know that. But the data on the ones who crash, it's pretty sobering.
Tell us about that mortality gradient.
Well, if you look overall, for all hospitalized patients, maybe mortality is what, 1% to 7%? Relatively low.
Okay.
But then you add in heart failure or significant ventricular arrhythmias.
Yeah.
That number jumps, more than doubles, maybe up to 12%.
Wow.
And then the really sick ones, the ones needing advanced hemodynamic support, ECMO, Impella, they're in cardiogenic shock.
Mortality
Can be up to 28%. In hospital death or needing a transplant. So the message is really clear. If they get sick with this, they get critically sick.
Which brings us straight to that first absolute critical decision point, triage. Where does this patient go? Ward or ICU? This is like step one in risk management.
It's non-negotiable. You have to draw that line correctly. The general ward, that's reserved for the stable patient.
Define stable in this context.
Okay, so think the infarct-like presentation. Chest pain, maybe some troponin leak, but hemodynamically stable, electrically stable.
And I say crucially.
Crucially, preserved LVEF. Normal echo function is key here. No signs of decompensated heart failure, no bad arrhythmias, no significant conduction blocks.
These are the patients where you have time, maybe, for a planned CT angio sequential diagnostic.
Exactly. They're stable enough for that approach.
Okay, so conversely, any deviation from that picture means ICU.
Absolutely. ICU admission is mandatory. And it's not just for closer monitoring. It's about immediate access to advanced life support if things go south quickly.
So what are those specific triggers? The automatic ICU admits.
Any sign of severe ventricular dysfunction, so a reduced LVEF, biventricular failure, any hemodynamic instability, hypotension, needing pressors, signs of shock, that's an immediate ICU ticket.
And electrically.
Life-threatening arrhythmias. Think sustained VT, VF, or advanced AV block, Mobitz II, or complete heart block. Those need the ICU.
You also mentioned that sometimes the suspected cause itself pushes them to the ICU, even if they look okay initially.
Yes, that's a really important point. If you have a fulminant onset, like they were fine yesterday and crashing today, that's ICU. Or if you have high suspicion for those really aggressive, often non-viral types.
Like giant cell, eosinophilic.
Exactly. Giant cell, eosinophilic myocarditis, cardiac sarcoidosis. These demand ICU care because they can deteriorate incredibly fast, often irreversibly. And you might need urgent biopsy and targeted therapy, which requires the ability to deploy mechanical support immediately.
Okay, so we've triaged the high-risk patient to the right location. Now, let's talk about actually making the diagnosis, the initial workup. What's the classic presentation we should be looking for, often after that viral illness, right?
Yeah, that prodrome is common. Fever, URI symptoms in the weeks before. Maybe up to 2/3 report something like that. Then you get the classic triad.
Which is?
Number one, most frequent by far, is chest pain. Over 80% of cases. And this is the pain that looks so much like an acute MI. That's the big confounder.
Okay, chest pain. Number two.
Heart failure symptoms, or even frank cardiogenic shock. This can range from just a bit of shortness of breath, maybe some edema, all the way to flash pulmonary edema, severe hypotension.
And the third part of the triad, often the scariest.
Arrhythmia-related symptoms. So new palpitations they notice, syncope, or sometimes tragically, they present after a resuscitated sudden cardiac arrest.
Got it. So patient presents with one or more of these, maybe that viral history. What's the immediate workup in the hospital?
You need baseline labs, stat, CBC, CRP is important, high sensitivity troponin, of course, and natriuretic peptides like BNP or NT-proBNP.
And the ECG. Always crucial.
Absolutely. It's almost always abnormal. Reports say 60 to 95% show something, but it's often nonspecific.
But are there patterns that might steer you towards myocarditis rather than a classic MI? Especially with ST elevation, where the default might be the cath lab.
Yeah, that's a key distinction. In myocarditis, you often see diffuse ST elevation, maybe concave up, not fitting a specific coronary territory. You don't usually see those crisp reciprocal changes like in a plaque rupture.
What else on the ECG?
T-wave inversions are common, QTC prolongation, and really importantly for risk, watch for new conduction blocks, vesicular blocks, new bundle branch block.
And QRS duration.
Big flag. If the QRS widens out, say, over 120 milliseconds, that's associated with a worse prognosis, higher risk of bad outcomes.
Okay, labs, ECG. Next up is usually the bedside echo, right? Assessing function.
Indispensable. You need that echo quickly. Assess the overall LVEF. Look for regional wall motion abnormalities. Remember, these might not fit a standard coronary distribution. Also look for any pericardial effusion, which can happen.
But you mentioned earlier, a normal LVEF, especially early on, doesn't mean it's not myocarditis.
Exactly. The inflammation might be patchy, function might still be preserved initially, but the echo is critical for risk stratification. Is the EF reduced? That puts them in that high-risk bucket immediately. Is it preserved? Maybe they're lower risk, at least hemodynamically for now.
This really circles back to that huge diagnostic pivot. Is this myocarditis or is it ACS? That's the first hurdle for the hospitalist team.
It's the absolute gatekeeper decision. You simply cannot make a confident diagnosis of myocarditis until you've excluded obstructive coronary artery disease, period.
So for pretty much anyone coming in with acute chest pain and a troponin bump,
They need coronary assessment. Usually that means invasive angiography. If the suspicion for ACS is lower and the patient is stable, maybe CT coronary angiography is an option.
but you have to rule it out.
You have to. The urgency here is massive. Treating MI like myocarditis is bad, but treating myocarditis like an MI, especially if you give certain meds, can also be disastrous. You have to know what you're dealing with.
Okay, so let's say we've done the angio, the coronaries are clean. Now we're thinking strongly myocarditis. How do we confirm the myocardial inflammation non-invasively? That brings us to cardiac MR, right?
CMR.
Yes, CMR has really changed the game here. It's become the go-to non-invasive test. You could almost call it the non-invasive gold standard now.
That goes
way beyond just looking at anatomy.
It uses tissue characterization. Tell us about the criteria we're looking for. The Lake Louise criteria have evolved.
They have. The updated criteria really lean on parametric mapping. This gives us actual numbers, objective measures of tissue properties. We look at T1 mapping that assesses diffuse fibrosis and edema, and T2 mapping that directly measures myocardial water content, so edema and inflammation.
And having both. When you have abnormalities in both T1 and T2 mapping, the specificity for myocardial injury, non-ischemic injury, gets very high. It's a powerful tool.
And the pattern of injury on CMR helps too, right? distinguishing it from ischemia.
Exactly. With myocarditis, you typically see enhancement, that's the scarring or inflammation in a patchy pattern, often in the subepicardium, so the outer layer, or the midwall. Ischemic injury classically starts subendocardially, the inner layer, so the pattern is a big clue.
So CMR confirms inflammation and helps rule out ischemia. But it doesn't tell us why there's inflammation. It doesn't give us the etiology.
That's the limitation, yeah. If the patient's stable, doing okay, maybe CMR is enough diagnostically, we manage their symptoms, support them. But for the really sick ones, the ones who aren't getting better or the ones where we suspect a specific cause that needs targeted treatment,
Then we have to think about the invasive option.
then we have to consider endomyocardial biopsy, EMB, the true gold standard for etiology.
But it's invasive. It has risk perforation, arrhythmias, valve issues. The ACC guidance is pretty restrictive, isn't it?
Very restrictive, and rightly so. It's reserved only for those high-risk patients where getting that tissue diagnosis will actually fundamentally change your management plan.
So who meets that bar? What are the specific indications?
You need unexplained acute cardiomyopathy, meaning the heart function is down, and it's accompanied by either hemodynamic instability shock, needing support, or significant electrical instability.
Refractory arrhythmias, high gray block.
Exactly. Refractory VT, needing pacing for advanced AV block. Or another key indication is if the patient just isn't responding to standard guideline-directed heart failure therapy within, say, 1 to 2 weeks. If they're stuck or getting worse despite everything, you need to know why.
And the value of that biopsy, that piece of tissue, is twofold, right? Histology and molecular tests.
Critical. First, the histology tells you what kind of inflammation it is. Is it giant cell? Is it eosinophilic? Is it sarcoidosis? Because the treatment is radically different.
And the second part?
Molecular testing, specifically viral PCR on the tissue. This is absolutely essential. You need to know if there's active viral replication in the heart muscle.
Why is that so critical?
Because you cannot give high-dose immunosuppression, like steroids, if there's an active viral infection driving the myocarditis. That could make things much, much worse. So you need the biopsy results, both histology and viral PCR, before you even consider immunosuppression.
That makes sense. Let's dig into those causes then. Understanding the etiology is the bridge to that targeted therapy. Viruses are the most common trigger, you said.
Yeah, viruses still lead the pack worldwide. We see the enteroviruses like Coxsackie, parvovirus B19, HHV6, influenza, and obviously SARS-CoV-2 has been a big player recently.
But the really aggressive, rapidly fatal forms are often not viral.
Often, yes. That takes us into the immune-mediated and autoimmune causes. And we seem to be recognizing these more and more.
What falls into that category?
Things like systemic diseases affecting the heart, cardiac sarcoidosis is a big one, SLE sometimes. Then you have drug reactions, hypersensitivity, myocarditis.
And the immune checkpoint inhibitors, the ICIs.
Huge focus there now. ICI myocarditis is rare but incredibly aggressive, very high early mortality if you miss it or delay treatment. And we also track the rare post-vaccine cases, like with mRNA, COVID vaccines, or smallpox vaccine. Also immune-driven, though typically less severe than ICI cases.
So this huge range in severity we see clinically, from just chest pain to fulminant shock, it must be driven by the underlying pathophysiology, right? This sort of two-phase injury idea.
Exactly. Phase 1 is the initial hit, direct myocyte injury, maybe a virus gets in, causes some cell death, necrosis.
But the real damage comes later.
The real persistent destructive inflammation often comes in phase 2. That's driven by the host's own immune response. T cells infiltrate, adaptive immunity kicks in, sometimes you get autoantibodies against heart proteins. This whole process can keep going long after the initial trigger, like the virus, might be gone.
And there are specific molecular signals amplifying this, right? You mentioned DAMPs in the source material damage-associated molecular patterns. Can you unpack that a bit? How does necrosis fuel ongoing inflammation?
Sure. So when heart muscle cells die, they basically burst open and release their contents. Some of these contents are molecules that aren't normally outside cells. These are the DAMPs.
Okay.
Immune cells have receptors, like toll-like receptors, TLRs, that recognize these DAMPs as danger signals. It's like a big alarm bell.
Triggering what?
Triggering the recruitment and activation of more immune cells, especially inflammatory monocytes that turn into macrophages right there in the heart tissue. They come rushing in.
And those macrophages and T cells, they then contribute to more damage.
Yes, they release cytokines, enzymes, reactive oxygen species.
Oh.
It becomes a cycle of inflammation and injury.
The source material also mentioned complement activation and even mitochondrial injury playing a role.
That's right. Complement, part of the innate immune system, can get activated and directly damage heart cells. Sometimes viruses even interfere with the heart's natural complement protection, making it worse, and damaged mitochondria inside the cells. They can release their own pro-inflammatory signals, kind of feeding back into that inflammatory loop, keeping it going.
It sounds like a vicious cycle that can really spiral. But if it's so potentially severe, why do some people recover fully while others go on to chronic heart failure? Is there an underlying susceptibility?
That's the million-dollar question, and increasingly the answer seems to involve genetics. We're finding that some people have pathogenic variants, mutations in genes coding for important heart muscle proteins.
Like structural proteins?
Yeah, things like desmosomal proteins, DSP is one, or that huge sarcomeric protein, titin, TTN. These variants might not cause disease on their own, but they make the heart muscle, let's say, more fragile.
So when the inflammatory insult hits,
Their heart can't handle it as well. They're more likely to have severe damage, less likely to recover fully, and much more likely to progress from that acute myocarditis episode to chronic dilated cardiomyopathy down the road.
which really underscores the need to think long-term, even from the acute admission.
Absolutely. It connects the dots between the acute event and potential lifelong implications, maybe even for their family members.
Okay, let's transition now to actually managing these patients once they're admitted. Starting with the basics. Supportive care. This applies to everyone, right? Ward or ICU.
Yes, supportive care is foundational. Every single patient with suspected or confirmed myocarditis needs continuous cardiac monitoring. Even if they look stable initially, things can change fast.
And medication review.
Meticulous review. Stop any potential offending drugs, toxins, supplements. You need to clear the decks of anything that could be contributing.
Now, pain management. This comes up a lot, especially with that chest pain presentation. Big caution around NSAIDs, right?
Huge caution. This needs to be emphasized. NSAIDs are generally contraindicated, strictly avoided, in any patient who has signs of heart failure, a reduced LVEF, or is in shock.
Why is that?
They can cause sodium and water retention, worsening heart failure. They can cause kidney injury, especially if hemodynamics are shaky. And there's theoretical concern they might actually worsen myocardial inflammation. The risks just outweigh the benefits in those patients.
So when can you use NSAIDs? Is there ever a role?
Only really for that specific subset. The stable patient, preserved LVEF, no heart failure, presenting with that infarct-like or pericarditis-like chest pain. In that select group, a short course of NSAIDs might be considered. Or maybe weight-adjusted colchicine, which has some anti-inflammatory effects used in pericarditis.
But for anyone with ventricular dysfunction or heart failure,
Stick to acetaminophen, maybe low-dose narcotics if needed, cautiously, but avoid NSAIDs.
okay. Now for the high-risk patients, the ones with reduced LVEF, maybe signs of heart failure, we move straight to guideline-directed medical therapy.
Yes, you apply the standard HFrEF protocols. Get them on the 4 pillars as tolerated.
Diuretics, ACE-Barney, beta blocker, MRA, SGLT2 inhibitor.
Exactly. Titrate them up, but you have to be cautious, watch their hemodynamics closely. If they're really sick, in shock, then stabilizing them comes first, medications second.
Which leads us to the really critical interventions for the sickest patients.
Yeah.
Advanced therapies, mechanical circulatory support, MCS. This is where the hospitalist needs to act fast and get consultants involved.
Yeah, time is myocardium, especially in fulminant myocarditis. If the patient isn't responding to initial medical therapy, maybe they're on pressors like norepinephrine, maybe some inotropes like milrinone, but they're still failing, you have to escalate to MCS immediately. Don't wait.
What are the options there?
For severe cardiogenic shock, often VA ECMO is the first choice. It provides both heart and lung support, lets the inflamed heart rest completely. Other options, depending on the situation, could be an Impella device, maybe an intra-aortic balloon pump, though that provides less support.
And the timing of assessing recovery on support is crucial. The sources mentioned a tight window for deciding about long-term options.
Very tight. If recovery is going to happen, most of it tends to occur within the first, say, 2 weeks on support. So if you're 10, 14 days in, max support, and there's just no sign of the heart function improving EF still down, still need high support, you have to pivot.
Pivot to what?
Pivot immediately to evaluating them for durable support, like a long-term LVAD or getting them listed for heart transplantation. Delaying that decision if recovery isn't happening just leads to worse outcomes.
Got it. Let's talk about the electrical side. Arrhythmias are a big part of the picture.
Huge. Continuous monitoring catches sustained VTach or VFib, which you treat with standard ACLS protocols, antiarrhythmics like IV amiodarone, defibrillation.
And bradyarrhythmias, heart block.
Advanced AV block can happen. It's often transient in myocarditis related to the inflammation near the conduction system, but if it's causing hemodynamic problems, they might need temporary transvenous pacing until it resolves.
What about putting in a permanent ICD before they leave the hospital?
That's a very selective decision. For most myocarditis patients, even if they had arrhythmias acutely, you want to wait. You follow standard secondary prevention guidelines, often reassessing function and arrhythmia burden after 3 to 6 months, giving the heart time to heal.
So who does get an ICD early?
Only really specific high-risk groups. Patients with persistent, life-threatening ventricular arrhythmias despite medical therapy. Or, importantly, patients with a biopsy-proven diagnosis of something highly arrhythmogenic, like cardiac sarcoidosis or giant cell myocarditis. Those conditions carry such a high risk of sudden death, you often place the ICD before discharge for primary prevention.
Okay, that brings us to the most targeted and maybe most controversial area, immunosuppression. You've stressed this is not routine. Why the caution?
Because, as we said, most myocarditis is likely triggered by viruses. Giving high-dose steroids or other immunosuppressants when there's active viral replication could theoretically worsen the infection, suppress the helpful immune response, and lead to worse outcomes. It's a major concern.
So the absolute requirement is?
Biopsy confirmation. You need histology showing a non-infectious immune-mediated process, and you need negative viral PCR from the heart tissue before you pull the trigger on immunosuppression.
And which biopsy results mandate this kind of therapy?
The big ones are biopsy-proven giant cell myocarditis, eosinophilic myocarditis, cardiac sarcoidosis, and immune checkpoint inhibitor, ICI-related myocarditis. These are diseases where the immune system itself is the primary enemy attacking the heart.
What do the regimens look like? Is it just steroids?
Often starts with high-dose IV steroids like methylprednisolone, maybe a gram a day for 3 days, then transitioning to a slow oral prednisone taper over months.
But sometimes you need more.
Yes, especially for the really aggressive forms. Giant cell myocarditis, for example, has a terrible prognosis if you only use steroids. It requires immediate multi-drug immunosuppression.
Like what?
Usually high-dose steroids plus a calcineurin inhibitor like cyclosporine or tacrolimus. Sometimes other agents like azathioprine or mycophenolate are added to. It's heavy-duty stuff.
And for ICI myocarditis?
High-dose steroids are first line there too, but it's often refractory, so you might need to escalate quickly to other agents, biologics like abatacept, or even things like antithymocyte globulin if they're not responding.
This sounds incredibly complex. Definitely needs a team approach.
Absolutely essential. Managing these requires input from rheumatology, maybe immunology, definitely the advanced heart failure team. These are complex drugs with serious side effects, needing specialized monitoring long-term. It's way beyond routine hospital medicine.
Okay, so patient is stabilized, may be treated. Now we're thinking about discharge and what happens next. Prognosis varies wildly, doesn't it?
Massively. It really depends on how sick they were initially. If you had that uncomplicated presentation, preserved EF, no major arrhythmias, stayed on the ward, your long-term outlook is actually excellent. Very low cardiac mortality, likely less than 5%, assuming you follow precautions.
But the ones who are in the ICU, on support.
Much tougher road. For fulminant myocarditis needing MCS, the risk of death or needing transplant within the first couple of months can be, as we said, over 25%. Certain things predict a worse outcome. If both ventricles were affected, if the QRS stays wide on the ECG, and simply needing that high level of mechanical support tells you the injury was severe.
And long-term, even for survivors of severe episodes, there's that risk of chronic heart failure developing later.
Yes, a significant minority, maybe 12% to 25%, might progress to chronic dilated cardiomyopathy or die from cardiac causes later on.
Is there anything on imaging that predicts that long-term risk?
Yes, residual fibrosis on follow-up CMR is a big one. If they do a CMR months later and see persistent late gadolinium enhancement, especially if it's extensive or in certain locations like the septum, that's a strong predictor of future problems, heart failure, arrhythmias, sudden death.
Which really hammers home the need for structured follow-up after they leave the hospital.
Mandatory. It can't be haphazard. Anyone who had symptoms of heart failure or reduced EF needs to be seen quickly, probably within a week of discharge. Repeat echo is needed early, maybe 2-4 weeks, to see how function is recovering.
And repeat CMR.
Ideally, yes. Repeat imaging, preferably CMR, around 6 months out, is recommended to see if the inflammation has resolved and to quantify that residual scarring, the fibrosis, which has prognostic value.
Now, the single most important discharge instruction may be the hardest one for patients to follow.
Activity restriction, physical activity restriction. This is non-negotiable.
For how long and who needs it?
Everyone diagnosed with acute myocarditis needs it. Advise against any high-intensity exercise, competitive sports, heavy exertion for a minimum of 3 to 6 months. Minimum.
Even if their LVEF recovered quickly, even if they feel fine.
Yes. Regardless of initial LVEF or how good they feel, the heart muscle is still healing during that period. Strenuous activity can potentially worsen inflammation, trigger arrhythmias, or even cause sudden death. The risk is real during that vulnerable phase.
So after that 3-6 months, how do you clear them to go back to sports or heavy activity?
You need evidence of recovery. Biomarkers like troponin should be normal. Ventricular function on echo should be completely normalized. Ideally, inflammation resolved on imaging if available. And then the guidelines suggest considering functional testing maybe a 24-hour Holter monitor to check for arrhythmias and an exercise stress test. But only after that 3-6 month rest period is complete. You can't rush return to play.
Okay, so wrapping this up, this deep dive really highlights how complex myocarditis is in the hospital. It's all about that early aggressive risk stratification, getting the really sick ones the support they need, like MCS, fast.
And on the flip side, being really judicious, really evidence-based about using powerful treatments like immunosuppression only when you have that definitive biopsy-proven etiology.
That blend of aggressive support but cautious targeted therapy seems key.
It is. But as we get better with diagnostics like CMR and genetics, it pushes us to think beyond just the hospital stay.
Which brings us perfectly to that final provocative thought for you, the listener. We're increasingly recognizing these genetic factors, right? Variants in genes like DSP or TTN that seem to make people more susceptible to getting severe myocarditis or progressing to DCM after the acute hit.
Yeah, that field is exploding.
So the question for us as hospital physicians is, how should we start thinking about integrating genetic counseling, maybe cascade screening for family members, into the discharge plan and long-term follow-up for patients who survive acute myocarditis, especially the severe forms? Where does that fit in our future practice?
That's definitely the next frontier, managing not just the acute fire, but the long-term risk and the potential familial implications. Lots to think about there.